Firstly, let's talk about definition. What does it mean cephalometric? Word cephalometric consists of two parts: cephalo, it means head, and metric or measurements. So cephalometry is the analysis and the interpretation of standardized radiographs of the facial bones. Contents of our lecture: introduction, history, characteristics, landmarks, planes, conclusion, and of course references. Introduction. Cephalometric radiographs are used in orthodontic diagnosis to evaluate the pre-treatment dental and facial relationship of a patient, to evaluate changes during treatment, and to assess tooth movement and facial growth at the end of treatment. In the cephalometric assessment, certain carefully defined points are located on the radiographs, and linear and angular measurements are made from these points. The expressions of these measurements in various ways produce analysis of skeletal size and form. History. Interest in measuring the human form and skull has been around for millennia. The history of cephalometric analysis stems from Egyptian and Greek attempts at human body measurement. Anthropometrics. The term cephalometric is sometimes confused with craniometric. The former refers to measurement of the skull. The latter refers to measurement of the head, including the soft tissue, be it living or dead. All history of cephalometric analysis is divided into pre-Röntgen and Röntgen parts. 4,000 years before Christ, Egyptians wrote canon of proportions. It was a mathematical system developed to give idealistic proportions to the human form. Artistic forms were generated using a grid system. Evidence of attempts at orthodontics and tooth bringing system using the wires have been found among the human remains of ancient civilizations. The idea that modern-day orthodontics may have originated thousands of years ago is centrally intriguing. This remaining ancient physical evidence of attempts at orthodontics indicates that the dentition and facial appearance were as important then as they are today. Although not strictly related to cephalometric contributions, attempts down through time have been made to qualify and quantify the human form by type. I hope you know this man. It is father of medicine, Hippocrates. Hippocrates described two body types: habitus physicus, long thin body, and habitus apoplecticus, short thin body. Kretschmer in 1921 proposed his own classification of humans' body types: ascenic, it means thin, small and weak; athletic, muscular, large boned; picnic, stocky, fat; and dysplastic, unproportionate body. Sheldon, American psychiater, in 1954 proposed divide humans' body types into three types: endomorph, tending toward body fat; mesomorph, tending toward musculature; and ectomorph, tending forward undeveloped muscle. Like here: ectomorph, mesomorph, and endomorph. You know this man too. It is Leonardo da Vinci, arguably the first to try and systematically measure the head. It is part of his scientist's work, where he described and measured and tried to find proportions of human's cranium. Albrecht Dürer, you know, it is artist, but he treatise on cranial measurements was the first published work in which anthropometry was applied to aesthetic. And of course, you know Pierre Fauchard published The Surgeon Dentist in 1728. Some consider him to be the inventor of orthodontics. Some of the less than modern methods of straightening teeth included finger pressure, mental plates, lash to abutment teeth, extractions, and the use of the surgical instrument of the time, called the pelican. This instrument was used to make large phospholingual to buccal tipping movement. Petrus Camper introduced the facial angle, facial line, and horizontal plane, called Camper horizontal line. Joachim Lafolion coined the term orthodontia. He wrote his work Dentistry in 1841. Andrews Retzius, credited with introducing the terms orthognathic, prognostic, and the cephalic index. And modern era of cephalometry, Röntgen leads the way. In 1895, Röntgen discovered X-rays. Röntgen discovered X-rays in 1895 and submitted the paper on a new kind of rays, a preliminary communication. The following year, Koenig and Walkhoff simultaneously made the first dental X-ray of a tooth. But, doctors, there are few features. In 1881, Ukrainian scientist Ivan Poluy discovered and patented X-ray lamp. It was 14 years before Röntgen. But due to some events, Ivan Poluy was forgotten. 1922, Paul Simon becomes the first to use planes and angles in the diagnosis of dental anomalies. 1948, William Downes is credited with developing the first cephalometric analysis. Over the ensuing years, multiple cephalometric analysis methods have been established. But Downes' analysis is used till nowadays. And many other doctors, like Steiner, Twiss, Sassoon, Harvell, Twiss, Ricketts, McNamara, Jarabak, proposed their own analysis. So, doctors, I found this picture. It is a picture of School of Dental Medicine, University of Pennsylvania, 1915. You can see how many students studied at that school. Let's talk about characteristics. At first, I would like to show you methodics, how to take the cephalometric X-ray.
This video will show you how to perform a Progeny Vantage panoramic cephalometric exam. Before conducting any clinical procedure, service, or maintenance operations, always refer to the appropriate technical documentation for the complete list of instructions, safety alerts, and sequence of procedures. The following steps will be covered in this video. First, choose the appropriate Ceph functions. Second, explain the exam to the patient. Third, properly position the patient. And last, acquire the image. To begin, tap the projection button on the top right of the Vantage Touch control screen to select the Ceph function. Verify the technique factors according to patient size and anatomy. Next, determine the Ceph study needed for the patient and select desired function. To do this, there are three cephalostat functions, which are the AP, the image taken from the anterior to the posterior of the head, or Bayesian toward the tube head; PA, the image taken from the posterior to the anterior of the head, Bayesian opposite the tube head; and lateral left or lateral right. The otic posts are in line with the X-ray tube head. Rotate the cephalostat to the proper position based on the desired function or study type. Rotating the cephalostat will automatically configure the system for the chosen cephalometric study type. Now that the Ceph function is chosen, explain the examination to the patient. Use a sanitary wipe or barrier on the Bayesian marker and place the ear speculums on the otic posts. Explain where the patient will stand under the cephalometric attachment. Ask the patient to remove glasses and mouth or facial piercings, as well as a jacket or bulky sweater. You should now ready the machine for imaging to be in the patient entry position. To begin the image acquisition, tap the Ready for Imaging button on the touch control panel. The status indicator flashes Wait to indicate a moving status while the Vantage system moves to the ready position. Once the Vantage system is ready to perform a scan, the status indicator will change to green ready state. With the patient standing next to the unit, visually compare the height of the patient's otic canal with the cephalostat ear posts. Adjust the height of the cephalostat until the ear posts are approximately the height of the patient's otic canal. Grasp the otic posts at the top and move it out to position the patient. The posts are designed so that they will not move except when grasped at the top. Next, rotate the Nasian marker up and help the patient to enter the set. Using the up-down control buttons on the secondary collimator or on the side of the patient positioning table, adjust the height of the Vantage system until the ear posts are approximately level with the patient's otic canal. Grasp the Nasian and slide it vertically until it aligns with the bridge of the patient's nose. Slide the Nasian toward the patient's nose until the tip contacts the bridge of the nose. For projections where the Nasian is not needed, it will rotate about the base out of the projection area. The patient's head position should be reviewed to make sure it is correct along 3 axes. From a side lateral view, the Frankfurt plane, bottom of orbit to otic posts, should be level horizontally. From a frontal view, the patient's face should be straight forward without any twisting. Also from the front, ensure the patient's head is not tilted but vertically straight. With the patient properly positioned, ask the patient to close their mouth, take a deep breath and swallow, place their tongue on the roof of their mouth, then remain as motionless as possible until the device stops moving and they are instructed on what to do next. Step back at least 2 meters, 6 feet, away from the Vantage system, but not toward the patient, and press and hold the exposure button until the Vantage system stops moving. When the image preview appears on the touch control panel, release the exposure button and verify the image acquired is the one desired for the patient. Tap OK to close the image window. If the exposure button is released before the Vantage system stops moving, the message "Procedure was interrupted before completion" appears. Click OK on the message window and wait for the Vantage system to recover and to determine if the image preview appears. 1. If it does, verify the accuracy of the image. 2. If there is no image or the displayed one is inaccurate, retake the image. Release the patient from the cephalometric by rotating the Nasian up and pushing out the otic wands. Help the patient exit the Vantage system. For more detailed information about how to perform a cephalometric examination, please refer to the Progeny Vantage Panoramic X-ray System User Guide. For further support, contact Midmark Support Services at 1-800-MIDMARK or visit www.midmark.com.
And now, let's continue to talk about characteristics. First one. The chosen landmarks and measurements can be altered by various procedures. The comprehensive appraisal includes all of the facial bones and the cranium base reference. Measurements can be readily transferred to a study cast. Critical facial skeletal components are examined. For variations in age and sex standards are available. Computerized systematic approach to measurement can be used. And now, next chapter of our lecture, landmarks. How landmarks are classified? First classification, it is classification based on the origin. Cephalometric landmarks and points are classified in the following two types: anatomical landmarks and points and derived landmarks and points. What does it mean? Anatomic landmarks and points. These landmarks represent the actual anatomic structures of the skull. Example gratia: nasion, point A, point B, ANS, anterior nasal spine, PNS, posterior nasal spine, etc. Instead of derived landmarks and points, are landmarks that have been obtained secondarily from anatomic structures in the lateral cephalogram or frontal. For example, gnathion, anterior point of occlusion, etc. Another classification: cephalometric landmarks based on structures involved. Based on hard tissue cephalometric landmarks and soft tissue cephalometric landmarks and points. Hard tissue cephalometric landmarks and points represent the actual hard tissue structures of the skull, such as nasal bone, ethmoidal bone, frontal bone, maxillary bone, mandible and hyoid, etc. Examples of hard tissue cephalometric landmarks are nasion, sella, menton, gonium, and others. But soft tissue cephalometric landmarks and points, categorized as soft tissue cephalometric and connect with soft tissues like forehead, nose, lips, chin. And examples of soft tissue cephalometric landmarks are soft tissue nasion, subnasale, stomion, soft tissue pogonion, soft tissue gnathion, and many others. Then, next group of classification: cephalometric landmarks based on the type or site involved. According to this sign, cephalometric landmarks can be unilateral or bilateral. What does it mean? Unilateral cephalometric landmarks and points are cephalometric landmarks or points situated in the midline. Examples of that points: nasion point, point A, point B, menton, etc. But bilateral cephalometric landmarks or points are cephalometric landmarks found on both right and left side. Examples of that landmarks are gonium, articulare, upper 6, lower 6, etc. And they are shown a full scheme of classification, cephalometric landmarks and points. All cephalometric landmarks and points are divided into hard tissue and soft tissue, and every this group are divided into anatomic or derived, anatomic or derived. And every of these subgroups are divided into unilateral and bilateral. Unilateral and bilateral. The same. Moreover, cephalometric landmarks or points are divided into related to cranial bones like frontal bone, nasal bone, ethmoid, temporal bone, sphenoid bone, occipital bone, dentition, mandible, maxilla, related to pharynx, oropharynx, laryngopharynx, and related to cervical vertebrae, like hyoid bone. Now let's talk about landmarks related to cranial bones. They divided into related to frontal bone, ethmoid bone, nasal bone, temporal bone, sphenoid bone, occipital bone, and zygomatic bone. Related to pharynx, oropharynx and laryngopharynx, and related to hyoid bone. Landmarks on cervical bones, related to hyoid bone or vertebrae. Moreover, landmarks on facial bone and dentition are divided into related to maxilla, to dentition, into mandible. And soft tissue cephalometric landmarks. And now let's talk more detail about different groups of cephalometric landmarks. Cephalometric landmarks related to frontal bone. As can you see, there are only 4 landmarks. First one, the most important, nasion. Abbreviation N. Nasion is abbreviated using English alphabet and is expressed as capital letter or uppercase N. Definition: nasion is the most anterior point of the frontonasal suture in the midline. This point is present almost in all cephalometric analysis. Supraorbitale point is the most anterior point of the intersection of the shadow of the roof of the orbit and its lateral contour, like on this X-ray or like on this scheme. Roof of the orbital cavity is formed by the bone between the anterior cranial base, cranial fossa above and the orbital cavity below. Main landmarks related to ethmoid bone. There are 5 landmarks: temporally neck of the cristagale, medio-orbitale, sphenoethmoidal point, and ethmoidal point. The most important are temporally. It is the intersection of the shadows of the ethmoid and the anterior wall of the infratemporal fossa, like here. Sphenoethmoidal point, the intersection of the shadow of the greater wing of the sphenoid and the cranial floor, as seen in the lateral cephalogram. Ethmoidale point. It is the deepest median point of the anterior cranial fossa, corresponding to the cribriform plate of the ethmoid bone. Landmarks related to nasal bone. There are only 3 points: nasion, frontonasal, and rhinion. Nasion point is the suture between the frontal and nasal bone. Rhinion. It is the most anterior inferior point of the tips of the nasal bones, as seen from normal lateral cephalometric X-ray. Landmarks related to temporal bone. There are only 3 points too: porion-zygomatic arc and mastoidale, and the most important are porion point is the most superior point of the external auditory meatus. The superior margin of the temporomandibular joint fossa, which lies at the same level, may be substituted in the construction of the Frankfurt horizontal line. Landmarks related to sphenoid bone. As can you see, there are so much points, and the most important are next. Dorsum of sella. It is most posterior point of the internal contour of the sella turcica. Floor of sella or sella inferior. Floor of sella is the most lower point of the inner contour of the sella turcica or hypophyseal fossa. Clinoidale point. It is the most superior point of the contour of the anterior clinoid process. It is anterior border of sella turcica. And sella point is the midpoint of sella turcica or hypophyseal fossa. Pterygoid point. Pterygoid point, the most posterior point of the outline of the pterygopalatine fossa. Sometimes this point called eye kakadu. Why? Because this profile looks like kakadu, and this point localized like eye of kakadu, because this point sometimes called eye kakadu. Landmarks related to occipital bone. There are only 4 points, and The most important are bastion point. It is point at the center of the anterior border of the foramen magnum, at the base of occipital bone. Landmarks related to zygomatic bone. Only 2 points. Orbitale point is the most inferior point of the lower border of the left orbit. And temporale point, intersection of the shadows of the ethmoid and anterior wall of the infratemporal fossa. And landmarks related to facial bones and dentition. Cephalometric landmarks related to maxilla. As can you see, there are so many points, and most important are anterior nasal spine, ANS abbreviation. It is the tip of bony anterior nasal spine in the midline or median plane. And opposite point, posterior nasal spine, abbreviation PNS. The most posterior point at the sagittal plane on the bony hard palate. Point A. It is deepest point of the curve of the bone between the anterior nasal spine and dental alveolus. Prostion. Prostion is the lowermost point of alveolar process of premaxilla in the midline between two maxillary central incisors. Pterygomaxillary fissure is a bilateral teardrop shaped area of radiolucency, the anterior shadow of which represents the posterior surface of the tuberosity of the maxilla. The landmark is taken where the two edges, front and back, appear to merge inferiorly. Next, very important landmark, orbitale. It is the lowest point on the left infraorbital margin. Cephalometric landmarks related to dentition. There are so much points too, and the most important are next. Incisions superius incisalis is the incisal edge of the maxillary central incisor. But on this scheme, this point is marked not correctly, because we must use the most protrude incisor. We need to put this point here. Incision superius apicals, apex of upper central incisor, is the root apex of the most anterior maxillary central incisor. If this point is needed only for defining the long axis of tooth, the midpoint of the bisection of the apical root width can be used. Incision inferius incisalis is the incisal edge of the most prominent mandibular central incisor. Incisor inferius apicalis, apex of lower central incisor, is the root apex of the most anterior mandibular central incisor. If this point is needed only for defining the long axis of the tooth, the midpoint of the bisection of the apical root, width can be used. Anterior point of occlusion. For the occlusal plane, a constructed point, the midpoint of the incisor overbite in occlusion, like on this scheme. It is point of contact between upper central incisor and lower central incisor. Maxillary central incisor point is the most labial point of the crown of the maxillary central incisor. Mandibular central incisor, abbreviation L1, is the most labial point of the crown of the mandibular central incisor. Posterior point of occlusion. For the occlusal plane, the most distal point of contact between the most posterior molars in occlusion. For this patient, it is contact point between upper and lower first molars. In case of erupted or full erupted second molars, that point would be between second molars. On this scheme, this point is shoved not correctly. Must be between second molars. Maxillary first molar, U6, upper 6, is the tip of the mesiobuccal cusp of the maxillary first permanent molar. It is cusp which indicates into big key of occlusion, mesial buccal cusp. Mandibular first molar point, or L6, lower 6, is the tip of the mesiobuccal cusp of the mandibular first permanent molars. I letter means inferior. And cephalometric landmarks related to mandibula. On mandibula, there are present many different points, and the most important are next. Infradentale point is the most anterior superior point of the mandibular alveolar process, usually found near cement-enamel junction of the mandibular incisors. Point B. The point B is the deepest midline point of the mandibula between infradentale and pogonion. Pogonion point. Most anterior point of mandibular symphysis. Gnathion point is a point on the chin determined by bisecting the angle formed by the facial and mandibular plane. DD point is the most prominent point of the chin in the direction of measurement. Menton point. It is the most lower point of the contour of the chin. Gonium point. The midpoint mediolaterally on the posterior border of each gonian angle. We have two gonian angles, and in case of deviating right and left angles, we need put this point in the middle between two contours. Articulare. Articulare is the point of intersection of the dorsal contours of the processus articularis mandibulare and os temporale. Intersection. Condylant point. It is the most superior point of condyle of articular head. And now let's talk about soft tissue cephalometric landmarks. They can be anatomic or derived, and everyone is divided into unilateral and bilateral. Unilateral and bilateral. First point is soft tissue glabella, marked by G or GS or capital letters SGLB. Is the most prominent or anterior point in the mid-sagittal plane of the forehead at the level of the superior orbital ridges. Pronasale point is the most prominent or anterior point of the nose. Subnasale point is the point at which the nasal septum between the nostrils matches with the upper cutaneous tip of the mid-sagittal plane. Labralis superius is the most anterior point of the margin of the upper membranous lip. Stomion point is the median point of the oral embouchure when the lips are closed. Labella inferius is the most anterior point of the lower margin of the lower membranous lip. Soft tissue submentale or soft tissue point B. Hard tissue point B, localized here, but soft tissue point B or soft tissue submentale is the point of greatest concavity in the midline of the lip between labra inferius and soft tissue pogonium. And soft tissue pogonium is the most prominent or anterior point of the soft tissue chin in the mid-sagittal plane. Soft tissue gnathium is the midpoint between the most anterior and inferior points of the soft tissue chin in the mid-sagittal plane. And now, doctors, let's summarize information I told you earlier. Now let's talk about cephalometric planes. Cephalometric planes are derived from at least 2 or 3 landmarks used for measurements, separation of anatomic divisions, definition of anatomic structures of relating parts of the face to one another. And cephalometric planes are classified into horizontal and vertical planes. Horizontal cephalometric planes. Sella turcica to nasion point, SN plane, Frankfurt horizontal plane, from porion point through porion point and orbitally point, palatal plane between anterior nasal spine and posterior nasal spine of palatine bone, occlusal plane between contact point of first molars and central incisors, and mandibular plane. It is plane passes through gonion-gnation points. And vertical planes. Apogonion plane, point A on maxilla to pogonion on mandible. Facial plane through nasion and pogonion point. And facial axis, PTM point to gnathion point. And as a result of marking our landmarks and planes, a measurement of different facial angles. First one called facial angles. Inferior angle formed by intersection of Frankfurt horizontal line and facial plane. Average value 87.5, but can be from 82 to 95 degrees. Significance, indication of anterior-posterior positioning of mandible in relation to upper face. Increase of this angle we will observe in skeletal class 3 with prominent chin. Decreased in opposite situation in skeletal class 2. Angle of convexity. It is plane between nasion point and A point, and A point pogonion point. In normal situation, these two planes are overloaded, and average value, of course, will be 0, but can be from -8.5 to 10 degrees. Significance of this point, of this angle. Positive angle suggests a prominent maxillary dental base in relation to mandible, but negative angle is indicative of prognathic profile. AB plane angle. Plane AB between AB point, angle between AB point, AB plane and nasion-pogonium plane. Significance. Average value minus 4.6, but can be minus 9 degree to 0. Significance. Indicative of maxillomandibular relationship in relation to facial plane or facial vertical line. Positive in class 3 malocclusion or class 1 malocclusion with mandible prominence. Negative since point B is positioned behind point A. Y-axis. It is angle between Cephalometry to Frankfurt horizontal point, between Cephalometry line plane and Frankfurt horizontal plane. Average value 59.4, but can be normal values from 53 till 66 degrees. Significance of this angle indicates growth pattern of individual. Increased in class 2 facial pattern, vertical grown pattern of mandible, and this angle will decrease in class 3 facial patterns, horizontal growth pattern of mandible. And last cephalometric angle, mandibular plane angle. It is intersection of mandibular plane with Frankfurt horizontal plane. Average value of this angle is 21.9 degree, but from 17 to 28. And significance of this angle. A high mandibular plane angle is characterized by open bite skeletal patterns, but opposite situation, a low MPA, is characterized by closed bite skeletal patterns. And now let's see in one video pointing of that point in a base of EasyCeph computer program.
Calibration, point 1. Calibration, point 2. Distance between. Successful calibration. Click digitize button.
At first we need to calibrate
Nasion.
cephalometric X-ray.
Cella. Horian.
In this window
Asian.
they are shown tips
Pterygoid. Pterygoid reference.
and
Orbital.
their definition
ENS.
of every point.
ENS. R1. R3. A point. B point. PM. Pogonian. Menton. subgonian, supragonian, upper incisor edge, upper incisor root, lower incisor edge, lower incisor root, occlusal plane, upper molar distal, upper molar meshal, lower molar distal, lower molar meshal, upper profile.
We can mark profile of soft tissues. And they're shown tip for us.
Lower profile. Mandible outline.
Tip for next step. And text like tip.
Additional free line. Additional free line.
Maxilla contour, edge of orbita contour,
Additional free line.
clinoid bone contour, sella turcica contour,
Additional free line. Occlusal plane. Upper molar distal.
and we can choose a wanted analysis. And automatically all lines are showing, and we can correct different lines. Now it's showing correction step. Save results. And we can get results for every analysis for printing. We can choose another type of analysis, for example, McNamara analysis, or Steiner-Witz analysis or Jarebach analysis. Or Burston analysis or Ricketts analysis. And conclusion of our today's meeting. Please take home message. A simplified and relevant cephalometric analysis has been developed that is applicable to planning orthodontic treatment. This analysis evaluates both hard tissue and soft tissue with both vertical as well as horizontal aspects of the face. If a prime objective of orthodontic treatment is facial improvement, soft tissue analysis becomes paramount in treatment planning. And there are shown a list of literature you can use to learn this topic deeper. And at the end of our today's meeting, doctors, my wishes to you. Don't be like these persons. But be like this man. Be strong, doctors. Thank you.
Thank you, sir.